Hello, good morning, good afternoon. My name is J Mancebo, and I'm gonna to talk with you about when and how to wean the ventilator. These are my conflicts of interest, and when and how to wean from mechanical ventilation. It is central and fundamental process during the whole duration of mechanical ventilation. Once the patients are intubated and mechanically ventilated, immediately after the trachea is intubated, our main aim is to stabilize these individuals, providing full mechanical ventilator assistance, often with sedation, sometimes with muscle paralysis, and with relatively high intensity of assistance in terms of oxygen and pressures delivered to the respiratory system. Once the patients are stabilized, then we need to think in the withdrawal of ventilator assistance. And this occurs during a phase of recovery. And this phase is characterized by the fact that patients are likely to breathe without the ventilator because the underlying cause of respiratory failure has improved in terms of mechanics, in terms of gas exchange, in terms of hemodynamics, neurological status. And at this point, it is extremely important to screen for the possibility to breathe spontaneously. And the best test that we have for a proper screening is the F over BT ratio, which is measured in very rapidly after a couple of minutes of disconnection from ventilation. If this screening phase is positive, then we go on the confirmation test, which is allowing the patients to breathe by their own during a period of weaning, which is often between 30 and 120 minutes. And this, if this period is successful, then we proceed with extubation. And the main aims of the whole process is to withdraw the mechanical ventilator as soon as possible and to avoid extubation failure. The importance of arriving to the screening phase as soon as possible is shown in this slide. And on the horizontal axis, you see the pretest probability of success. And in the vertical axis, you see the positive predicate value, or the post-test probability of successful outcome. And you see that these tests, the F over BT, is extremely useful when the pretest probability is low, is below the 50%. And here in this example, for instance, if your pretest probability is only 40% and your patient, after testing the FBT below 105 is positive, the possibility of a successful extubation is about 70%. On the contrary, if your pretest probability of success is very high, so the patients are almost ready to be successfully extubated, the usefulness of this kind of screening test is very low, since it changes our probabilities in about 10%. This is a study conducted in patients who were very early in their weaning phase, when they still had not passed an F over BT test. and these were patients with that were in the recovery phase with a reasonably good gas exchange, with reasonably good mechanics at low levels of PEEP, were hemodynamically stable, and had no concerns regarding the neurological status, no need for urgent surgery, and these patients were submitted to a pressure support test just to be sure that these patients were able to properly assist the ventilator, and then they were randomized to follow a conventional progressive decrease in the pressure support assistance, or being weaned with a computer driven machine, which automatically decreased the levels of pressure support until arriving to minimal levels and declaring the patient ready for extubation. And here you can see that when this computer-driven strategy was compared to the usual weaning strategy, the time to successful extubation was significantly shorter, 3 days versus 5 days, in the computer-driven system. These automated systems to wean patients for mechanical ventilation, in general, give as a result a significant reduction in the weaning duration and in the duration of mechanical ventilation, and also of ICU stays. Interestingly, this is data on the new classification of weaning from mechanical ventilation, and in this large amount of patients, you see that about 75% of the total amount of patients were submitted to a first spontaneous breathing attempt, and among all these patients at this first attempt, 75% of them successfully passed the trial and were extubated. These were the simple patients. There were other groups, however, with with difficult weaning, this 14% between 2 days and 7 days, and other patients with prolonged weaning, more than 7 days. And in the patients with difficult weaning, as you can see here, the average duration of mechanical ventilation was about 9 days, with significantly higher mortality as compared to the simple weaning, about 15%. Whereas the patients with prolonged weaning, the duration of mechanical ventilation was close to 3 weeks, and the mortality was substantial. So this data indicates that as long as we prolong the weaning duration, the likelihood of having poor outcome also increases. Important steps in achieving an early and safe withdrawal of mechanical ventilation is to work together with a sedation and awakening trials, in the sense that the sedation and awakening trial, which is the withdrawal of intravenous sedatives, together with the spontaneous breathing trial. This is the best strategy as compared to the usual care only using spontaneous breathing trials. And here you can see that the patient's the duration of mechanical ventilation is significantly shorter in patients in whom these two strategies are taken in consideration, and also the strategy of awakening, so getting rid of sedatives and conducting spontaneous breathing trials are the best approach to shorten the duration of ventilation. In patients with difficult weaning, most of them who are with fluid overload or left ventricular dysfunction, no strategy guided with some biomarkers. In this study, with strategy guiding the diuretic administration according to BMP, this strategy gave as a result a significantly a shorter duration of ventilation, and also a significantly higher number of patients successfully extubated. Another issue that can lengthen the duration of mechanical ventilation is especially the diaphragm dysfunction. And in this study conducted in patients studied after the first wean attempt, the authors observed that patients with prolonged and difficult weaning had a substantial prevalence of diaphragmatic dysfunction, and also those patients having diaphragmatic dysfunction had longer ICU length of stay, and also had significantly higher hospital mortality in comparison with those without dysfunction of the diaphragm. An interesting approach is also the use of early physical and occupational therapy. And in this study, the authors showed that the patients submitted to early rehabilitation, these patients had a higher proportion, higher likelihood to return to independent functional status with as short as only 30 minutes per day of physical therapy. In patients with prolonged weaning, the most difficult to wean, most of whom are patients with tracheostomies. Here in this very specific subgroup of patients, the most efficient strategy to reduce the duration of mechanical ventilation is the disconnection from the tracheal collar at least once per day, as compared to a progressive withdrawal of mechanical ventilation. And in these patients, the rate of successful weaning was 1.4 times faster with the disconnection from the tracheal collar and allowing the patients to breathe spontaneously, as compared with pressure support ventilation. So in summary, the optimal withdrawal of mechanical ventilation is based in a simple, rigorous, and predefined strategy. The systematic screening is extremely important, and this is to be conducted very early when the pretest probability is low. And the good news is when this approach is done systematically, the majority of the screen patients, about 70%, are extubated successfully. And to this end, the closed loop ventilator system can manage the whole process of mechanical ventilation from an early stage until extubation. In difficult to wean patients, it's very important to detect the causes, especially diaphragm dysfunction and cardiovascular issues, and monitoring respiratory muscle output using other techniques such as echocardiography, lung and diaphragm ultrasounds, biomarkers, etc., are of much help. The ventilator settings are to be adjusted avoiding the extremes and to facilitate synchrony. And in the most difficult patients, the clinical practice taking into account the numerous non-ventilatory issues, such as the control of infections, proper sleep, good communication with the patients, nutrition, mobilization, etc., is also likely to help much in shortening the process of weaning from mechanical ventilation. I thank you very much for your attention.